Alright guys, let's get busy talking about our vaginal skin pathology. We're going to be talking about lichen sclerosis, lichen simplex chronicus, and lichen planus. You will notice that these all start with lichen, and I hope this word lichen can orient you to the fact that these are going to be skin or epithelium related processes. We're going to be talking about diseases of keratinized skin, like this skin here on my hand, as well as skin that is non-keratinized, like those on our mucosal surfaces, like inside of our mouth or inside of our vaginal orifice, for instance. And it's going to be our first two pathologies, lichen sclerosis and lichen simplex chronicus, that are largely going to be on keratinized skin, and then our lichen planus can be on both keratinized and non-keratinized skin. So let's go ahead and get busy by talking about our lichen sclerosis. And this is going to be an inflammatory condition of really unknown origin, so you don't need to know the pathophysiology for the step 1 exam. However, you do need to know some facts about who gets this disease process and what it's going to look like. So this is going to be most common in our perimenopausal patients or postmenopausal patients, so you can expect like age like 40 to 60s or 70s here in terms of the patient who's going to present with this. And it's going to look like a porcelain white plaque with violaceous borders. And now what does that exactly mean? So let's kind of review here. The porcelain white plaque is going to be what I'm outlining here, so you can see that this tissue is really shiny, almost like white porcelain. And then on the periphery we're going to have like this violaceous tissue. So violaceous tissue is oftentimes described as like purple or pink in appearance. And so you're going to see this combo with the lesion centrally looking white and porcelain and then peripherally looking violaceous. And additionally, we can have these plaques that can flake or slough because they can be itchy at times. And so you can imagine with increased itching, then you're going to have sloughing and irritation. And how this patient is going to present in a classic vignette is going to be our patient whose age approximately 45 to 60 or 70 with really severe itching. So this is just itchy, 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 itchy. This is going to be the chief complaint. And they can also complain of pain with intercourse and or defecation because these lesions can occur anywhere in the anopelvic region, and so they can infiltrate the anus or the vagina, and so any type of activity down there can cause pain in these patients. In terms of managing this patient, it's important to get a biopsy of this lesion because by its appearance alone, this silvery white plaque, this could be a squamous cell carcinoma or it can be lichen sclerosis. And so this punch biopsy is going to be really important because even though lichen sclerosis is a benign disease, the punch biopsy is going to rule out squamous cell carcinoma. And if we rule out squamous cell carcinoma, we can simply treat these with steroid cream. However, if it was squamous cell carcinoma, we'd have to go down a different route of management. In terms of the histology, if this indeed is just a simple lichen sclerosis, we're going to see atrophy of epidermal tissue, hyperkeratosis, and dermal fibrosis. And this makes sense, right? Hyperkeratosis is going to be extreme growth of that squamous layer, so you're going to expect a really thick layer of these squamous cells right up at the top here, which is a picture that I have for later, but this is showing you the hyperkeratosis layer where that would occur. And then dermal fibrosis also makes sense because I usually think of fibrosis as like scar-like appearing tissue, and you can see that this looks like a scar-like lesion. That white shiny porcelain-like skin is very much related to this hyperkeratosis and dermal fibrosis that you would expect to see on histology. However, it is unlikely that you'll see a picture of the histology on this exam, but I just wanted to mention it because it may come up in a question stem in written words. Let's move on now to talking about lichen simplex chronicus, which is going to be all about itching, and it's specifically going to be itching due to a secondary cause. So our etiology here is going to be habitual scratching or rubbing, and this is going to be secondary to another condition. So other conditions that I'm thinking about could be like eczema or a fungal infection like Candidal intertrigo. Perhaps someone is having an allergic reaction to some type of clothing that they're wearing chronically. These are all underlying conditions that could lead to chronic itching. And so essentially these patients are going to have some sort of underlying pruritic anopelvic disease. And I gave you guys some examples, but it could really be anything. As long as they're scratching, it's going to lead to this. And so our presentation is going to be this thick, leathery vulvar skin with or without signs of excoriation. And excoriation is a fancy word for scratching. And so you can see here in this circle that I'm highlighting, this is that thick, leathery vulvar skin. This is how it would appear, and it looks like someone's just been like really scratching and irritating that area for a long period of time. In terms of our histology, we would expect to see hyperplasia of the squamous epithelium, so very similar to what I was previously talking about with our lichen sclerosis. That keratotic layer is going to be increased. It's going to experience hyperplasia because it's trying to defend or protect our skin from all the damage that is occurring there. In terms of our management here, there's no cancer risk, and so it's going to be all about treating that underlying cause of the the itch here, and that should resolve this along with things like moisturizers. Lastly, let's wrap up by talking about our lichen planus, which is going to be really high yield on the step 1 exam because there are little minutiae that they love to ask about in relation to this disease. So let's start out by talking about some of the pathophysiology. This is all going to be T cell mediated, specifically our CD8 positive T cells, and we're going to find these T cells specifically at the dermal epidermal junction, and this is called interface dermatitis. And I want to highlight a few more things about the histology before we zoom in. We're going to be looking for things like hypergranulosis, sawtooth reedy ridges, and lymphocytic infiltrate. So keep in mind our lymphocytic infiltrate here is going to be our CD8 positive T cells. So as we zoom in and look here, we're going to notice some things here. So I want to point out here is a bunch of lymphocytic infiltrate. What I'm tracing along here is the border between our dermis and our epidermis. So let me go ahead and put that in green. This is our dermal epidermal junction with our dermis down below and our epidermis above. And normally in our dermis, we do not expect this many purple dots. There is a lot of lymphocytic infiltrate here. Usually this is a lot more pink and lacy and full of fibroblasts, which appear more pink, but this is just chock full of these lymphocytes here that are CD8 positive. And essentially, I want to point out something else. You're going to see that these borders, there's times where it kind of like stretches down here, and these are called like sawtooth reedy ridges. So like this really jagged appearance to this interface between the dermis and the epidermis is called sawtooth reedy ridges, and that's a high yield description that they like to reserve for lichen planus. Additionally, you're going to see hypergranulosis. So in my blue here, I'm highlighting this layer of cells that is full of granulocytes, and this is also going to be expanded during our lichen planus disease. And so these are some high yield things to note about our patients with lichen planus on biopsy. Now, in terms of the presentation, this is classically not going to present as someone with a vaginal complaint. This is going to be a person who's complaining of bilateral lesions that are described using a mnemonic called the 6 Ps. So the 6 Ps apply to disease that's usually going to be on the extremities. So we're thinking like the legs and the arms, and these are going to be pruritic lesions, so super, super itchy here. And they're going to be pink and purple. They're going to be planar, polygonal, and described as papules or plaques. So these are all hot words for describing lichen planus, and these we would expect on the extremities. But we're talking about vaginal disease here in this video. And so in our mucosal areas like the mouth or vagina, we actually expect something else, and that's going to be something called Wickham striae. And Wickham striae are going to be described as these lacy white reticular deposits. And so you can see here in this mucosal lining, we have this really like lacy reticular finding. They tend to be like really long and really thin, and this is characteristic of lichen planus in a mucosal distribution. So outside on keratinized skin, we're going to expect purple lesions, but on mucosal skin, we're going to expect white, lacy, reticular lesions. And this is a high yield distinction in order to be pointing out on test day in terms of our lacy white reticular deposits called Wickham striae on our mucosal surfaces. Now, I also want to mention that there are some epidemiological fast facts that they like you to know in terms of the connection with hepatitis C, as well as autoimmune conditions like vitiligo and ulcerative colitis. Those are oftentimes going to be present in the history of a patient who is presenting with lichen planus. In terms of our management here, it's going to be topical steroids because we know this is all about lymphocytic infiltrate. So if we give steroids, we're going to reduce some of that inflammation. And that's going to be the mainstay of treatment for this disease process, in which a lot of the pathophysiology is largely unknown. We just know what it looks like on histology and what its associations are. And in terms of treating it, we just use our steroids. So in terms of a high yield review for our lichen sclerosis, it's important to recognize those white porcelain plaques with our violaceous borders, and then knowing that it's going to be a punch biopsy that helps you differentiate from squamous cell carcinoma. A normal punch biopsy just showing atrophy of epidermal tissue and hyperkeratosis with no evidence of dysplasia like we would expect in SCC. In terms of lichen simplex chronicus, it's all about scratching and rubbing, and this is going to be due to something underlying, like perhaps a fungal infection in the groin. That would be a classic example on a question vignette. And then in terms of lichen planus, we have a bunch of fast facts to know in terms of the histology with our sawtooth reedy ridges and lymphocytic infiltrate, as well as the connection to hepatitis C and underlying autoimmune conditions, and then knowing that it's going to be our white Wickham striae that are lacy and reticular on our mucosal surfaces, and then our 6P mnemonic for our keratinized skin lesions. So I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye!